Welcome. Thank you for listening into this webinar. I'm thrilled to be joined by Dr. Ramez Eskander, my friend who has agreed to come and actually have this conversation today where we'll discuss the exciting new results that were presented at the ESMO Congress in Berlin and at the IGCS annual meeting in Cape Town. Before we really get into the clinical trial results, I just want to briefly take a moment to talk about another conference, the special conference in ovarian cancer research that took place in Denver in September of this year. Because the reason I want to do that is I want to just highlight it all starts with this. You know, every clinical trial results that we're going to discuss today is a result of many years of basic and translational research. We have to remember that. The special conference in ovarian cancer research is a really fascinating conference that happens every 2 years. And this year it had many, many exciting sessions. Without being able to go into any detail, I just wanted to highlight and explain kind of some of the things that were discussed. There was a session talking about tumor initiation, actually how does ovarian cancer begin? Multiple sessions discussed the role of the immune system in ovarian cancer and also investigated different ways that we may be able to actually improve immunotherapies that can help identify and eliminate cancer cells, hopefully in the future. There was a session on precision medicine. You know, it's really important as we develop new treatments that we understand how different changes found in the tumor tissue, we can use that to develop really targeted and specific treatments that can help eradicate ovarian cancer. And finally, there were several really impressive keynote sessions. One of them here mentioned that described research in understanding how does the ovarian cancer tumor change over time, and also as a consequence of the different types of treatments that we use. At these ovarian cancer research conferences, there's also typically a patient advocacy and survivorship session. And just to highlight a few of the presentations that were in this year's session, Dr. Catherine Pennington talked about the clinical trials that have been happening and are still ongoing to really investigate how we can prevent taxane-induced peripheral neuropathy, a common side effects for people with ovarian cancer. And there are several different presentations on how, for example, trial of exercise and lifestyle can improve the life for ovarian cancer patients, and also the biology of stress and resilience in ovarian cancer. The special conference in ovarian cancer research happens every second year. And the Rifkin Center for Ovarian Cancer Research, a nonprofit in Seattle, Washington, have actually then had their Rifkin conference on the years that the AACR has not had the ovarian cancer research. As you may have heard, OCRA, the Rifkin Center became part of OCRA earlier this year. So going forward, OCRA are very excited to be part of actually hosting these ovarian cancer research conferences. And the next one that we will be part of organizing will be in Philadelphia in the fall of 2026. At this year's ovarian cancer research conference, OCRA's president and CEO, Audra Moran, was able to actually share some exciting information from OCRA. You know, the work that has been going on for several years in developing what we call the Community Accelerated Research Exchange. And this platform has multiple parts to it. One is a living lab, which is a secure registry for ovarian cancer and uterine cancer patient data. Another is what we call the Discovery Lab, which will be a dynamic and interactive AI-supported data environment for researchers. And the hope for OCRA in creating this platform is, of course, that we may be able to be part of accelerating understanding and outcomes for ovarian cancer and uterine cancer patients. And so that's a very exciting approach that we hope to launch in the beginning of next year. So with that being said, let's turn our attention to the clinical trial data. And Ramez, thank you again for joining me. I have put this first slide up. I don't know if you want to start out talking a little bit about the keynote B96 study.
Yes, thank you for having me or giving me the opportunity to join you, Anna Mette. It's always a pleasure to engage, to talk about the science, to talk about where the future may take us, because I think one of the most promising things that will come out of this conversation is that there is tremendous amount of research and work being done to continue to identify effective treatment options to help prolong our patients' lives who are battling these malignancies. So it's a dynamic period of time. We're going to go over, I think, a reasonable amount of bit of data. I just want to reassure everyone, there's content on the slides that was put together, and Mette did a tremendous job. And it's really for reference so that you can look back and take a look at some of this data as you're looking to understand what it might mean. And I'm really excited about the community accelerated research opportunity, because as we gather data, and I commend OCRA for doing this, we're going to continue to learn more about our diseases and about the patients that are battling these malignancies. So as we transition, the Keynote B96 study, this was exciting because, as many of you are aware, for a long, long time, we've had trouble showing clinical benefit adding immunotherapy or immune checkpoint inhibitors, drugs like pembrolizumab or dostarlimab, into the treatment paradigm for ovarian cancer, showing a clinical benefit. But a few months ago, we had a press release indicating that Keynote B96 met its primary efficacy endpoint of progression-free survival. And then there was actually another press release that said that it also was statistically significant for overall survival, all of which is really provocative. And this study looked at platinum-resistant ovarian cancer patients, and they were treated with what many of us consider to be kind of the most effective chemotherapy backbone. Here you can see the design of the trial. Patients received either weekly paclitaxel with or without bevacizumab at the physician's choice. The majority of patients did receive bevacizumab that were treated on this trial, about three-quarters. And the experimental arm added pembrolizumab, which is an immune checkpoint inhibitor, to weekly paclitaxel with or without bevacizumab. You may also know about bevacizumab being termed Avastin, but we'll talk about it as bevacizumab here. Patients had 1 to 2 prior lines of therapy, and they were not allowed to have what we call platinum refractory disease. Think about this
Mhm.
as patients who progressed on their first exposure to platinum, or carboplatin that is, or progressed within a defined period of time after completion. And that can vary between 1 to 3 months, depending on the clinical trial design. And on the next slide, you'll see here that what we saw with the results of Keynote B96, this was presented first at ESMO, and then it was also shared at the International Gynecologic Cancer Society, IGCS, in Cape Town, was that you could see this is a think about it as a biomarker here in this ovarian cancer population, this CPS score, which is a
Mhm.
score that we use to discuss the expression of PD-L1. But then they also looked at the entire population. That's the word we use is the intent to treat, ITT. That's everybody, irrespective of biomarker. And you could see that there was a progression-free survival advantage, but also in the PD-L1 CPS score greater than or equal to 1, the overall survival benefit was about 4.2 months with a very similar hazard ratio.
Yeah.
So it met its endpoints. And Mette, I'd be keen to see what your thoughts are after having all these other prior studies that in ovarian cancer didn't show a benefit. Now we're waiting to see whether the FDA is going to grant this
I
approval with
know.
a date of February 20th. But what do you think?
No, I certainly hope so. It's really exciting that we finally have a regimen in ovarian cancer where we can incorporate an immune checkpoint inhibitor and get a benefit both in progression-free survival and overall survival. And also, actually, during the meeting in Berlin, there was a new and third press release, I believe, that also said that the overall survival endpoint also has been met in this intention to treat populations,
Mhm.
and so in all patients. Um, yeah, I think, we do know that weekly paclitaxel alone is a very effective treatment, but, very exciting that we now also can add an immune checkpoint inhibitor and get an even better response.
Yeah, I agree. And some people view this as a trial that had what we would consider the most effective control arm in the
Yes.
weekly paclitaxel, many of whom also received the bevacizumab therapy. So
Yeah.
exciting to see this data. We're eager to see what's going to happen with the regulatory FDA approval and if this option's available,
Yeah.
and go from there.
And finally, nice, as you say, there has been so many clinical trials previously, trying to include immune checkpoint inhibitor in first-line treatment. So it is really satisfying to finally have a positive readout for a phase 3 trial in ovarian cancer with immunotherapy.
Indeed.
Yeah. All right, we'll change to the next data, and this is actually also a presentation that was a set of data was presented both at ESMO and also at IGCS. I guess that happens for a lot of the results here. This is a 5-year follow-up of the Keynote 775 study, where the combination of lenvatinib with pembrolizumab was compared to treatment of physician's choice, which was either weekly paclitaxel or doxorubicin for patients with advanced recurrent endometrial cancer. I think this is really also a study that you know very well. So I'll let you talk a little bit more about it. I have put together in this presentation, they shared both overall survival outcomes and progression-free survival or outcomes after this 5-year follow-up. So
yeah, I think
please
firstly, I think it's important for everyone to know that this is already an approved regimen, meaning here in the United States and in many countries globally, patients with recurrent endometrial cancer who've had prior therapy and progress, prior chemotherapy and progress, have an opportunity to receive treatment with lenvatinib plus pembrolizumab. And that's based on the initial Keynote 775 data that showed an improvement in progression-free survival and overall survival. But one of the questions that we commonly ask ourselves is, what about with longer term follow-up? What are we seeing when patients are treated with these drugs? And here what you can see is that the benefit is preserved, meaning that if you look at this data in totality, you could see that the mismatch repair proficient population with longer follow-up, we have nearly a 6-month improvement in the overall survival, 5-year overall survival rate of 7% versus 16 in the lenvatinib pembro over physician's choice chemo, 12.2 months to 18 months. So nearly a 6-month benefit. And in the mismatch repair deficient, and I will just highlight to everybody, we know that immunotherapy works really well in the majority of mismatch repair deficient endometrial cancer. So that's why there's a very big difference in that population from 8.6 months to 31.9 months. So this gives us confidence, and it says, look, we have an FDA approval for this regimen. It is an effective regimen. And with longer follow-up, we see preserved benefit in these patient populations, both the mismatch repair proficient and the mismatch repair deficient endometrial cancer cohort. So for our patients who are battling recurrent endometrial cancer, it's just a reminder, don't forget about this regimen. This should be a regimen that you discuss with your treating physicians if you're dealing with cancer recurrence after you receive initial therapy. But one caveat is this trial didn't allow prior immunotherapy.
Got it.
So now we have many patients receiving immunotherapy earlier in treatment because of some of the recent phase 3 clinical trials and approvals. Nonetheless, there is a population of patients who don't receive immunotherapy with initial chemo, and this is a great opportunity for those patients.
Sure, that makes sense. And without going into much detail, as we already talked about, the progression-free survival data was also consistent with what we had seen before. And as you say, this is confirming that what we would expect and that the data hold, even also despite the fact that actually many people that were in the chemotherapy control group did go on to actually receive lenvatinib and pembrolizumab later on. So
I think that's an incredibly important point. Sometimes we hear this narrative about, well, I don't want to necessarily use that regimen now. It may be maybe some people perceive it to be a more difficult regimen for patients to tolerate, or they worry about side effect profile. But I will say pretty passionately, if you look at all of our studies recently and you look at clinical benefit, you can see that even when you have crossover from the control arm and patients receiving that same treatment, for example, here, if you started off with chemo and then you get lenvatinib and pembrolizumab, it doesn't abrogate the benefit. It doesn't get rid of that benefit, which means that really the goal is to use the most effective treatment strategy as early as possible to try to give patients the greatest magnitude of benefit, because we really don't know a priori when a patient's starting a therapy, how long are they going to benefit? Maybe they're going to be one of these patients that has a very dramatic response. We don't know at the start of treatment. And so I think with this data, it just, again, gives us that understanding. Let's use our most effective therapies as early as we can in the treatment course.
Good point. Very good point. Yeah. All right. We are going to, sorry, I can see here. We need to move back to ovarian cancer. And again, a third study that was also shared actually talked about this is the ROSELLA trial, and there was one set of results presented at ESMO and another set of results presented at IDS, but presentations at both conferences. At ESMO, they really looked at the ROSELLA trial and looked of the benefit of the regimen that we will discuss in a moment in people that have been previously exposed to a PARP inhibitor therapy, while in the IGCS presentation of the ROSELLA trial, they focused on investigating the benefits of this regimen in people, in older patients. So taking a step back and just talking about the ROSELLA trial, this is another phase 3 study in the recurrent platinum-resistant ovarian cancer patients that have finished enrolling. And we saw the first results presented from this study at ASCO earlier this year. The study is really comparing, again, a treatment similar to weekly paclitaxel. In this case, it's the drug nab-paclitaxel that was used here, which is one of the very effective regimens for platinum-resistant ovarian cancer. And in the control arm, people received nab-paclitaxel alone. In the experimental arm, people received a new drug called relacorilant combined with the weekly nab-paclitaxel. And this study enrolled people with high-grade serous ovarian cancer with 1 to 3 prior therapies. Again, no primary platinum refractory disease was allowed, and people must have had prior bevacizumab to enroll in this study. Do you want to just quickly mention, I can also talk about what is actually relacorilant?
Relacorilant. Yeah, it's actually very interesting because the way this, the identification of this, first of all, regimen and how we dose it emerged from a prior phase 2 trial because it's intermittent dosing of the relacorilant, meaning you don't take this oral medication continuously and you get weekly nab-paclitaxel, as you alluded to, Mette. And the thought is that these ovarian cancer cells express a glucocorticoid receptor, steroid receptor, and that signaling may affect the efficacy of chemotherapy. For example, it inhibits the ability of chemotherapy to drive cancer cell death via apoptosis, for example, which is the word that we use to describe how cancer cells ultimately die. So the thought was if we use this glucocorticoid receptor antagonist, a molecule that blocks that signaling pathway, we can sensitize more to the chemotherapy, which is the nab-paclitaxel or nanoparticle albumin-bound paclitaxel. And I will just add the reason you may ask, well, why didn't they just use regular weekly paclitaxel? Well, because they wanted to avoid steroid pre-medication because they're using a medication to block the steroid signaling pathway. So here, patients didn't receive steroid pre-medication when they received the nanoparticle albumin-bound or nab-paclitaxel in combination with relacorilant.
Yeah, and as mentioned, at ASCO 2025, they did present the initial data where they demonstrated that there was a significant improvement in progression-free survival with this combination compared to nab-paclitaxel alone. And they also showed the early data suggesting that there may be an overall survival benefit with this regimen. Now at ESMO, the results that they really were focused on was they wanted to look in people that had previously been treated with a PARP inhibitor therapy before they received this regimen, which is a large proportion of the patients that enrolled in this trial. Many people do get PARP inhibitor maintenance treatment as part of their first-line chemotherapy regimen and maintenance treatment. And what they did find was that the benefit of this regimen was, kept. They do see that both in people that had had prior PARP inhibitor, in all those people, but also actually in the people that had had progression while they were on a prior PARP inhibitor. So that's really encouraging to see. I don't know if you have anything to add about that.
No, I agree completely. Just again, adds confidence to the primary efficacy endpoint. And this is relevant because we don't know whether or not progressing on a PARP inhibitor can somehow affect response to next line of therapy. So if we have a combination strategy like this that continues to show a benefit, it just speaks to the potential efficacy of the strategy.
Exactly.
And as you alluded to, Mette, positive results were presented. There was a press release, the data was shared. And then now again, just like we alluded to with the Keynote B96, the FDA is going to review the data and tell us if there's an approval with a date in February of 2026. This is also under review with we call it a PDUFA,
Hmm.
the regulatory abbreviation for how the FDA gives us a decision about access to drugs. And this is in July of 2026. So theoretically, between February or prior and July or prior, we may have two new
Yeah,
regimens available for our patients who are dealing with platinum-resistant recurrent ovarian cancer.
yeah,
One, weekly paclitaxel with pembrolizumab and bevacizumab at physician discretion. The other, this relacorilant plus nab-paclitaxel weekly strategy. So again, I like to say I want options for the patients that I treat. And the more options I have, the more content I am as a treating provider, because independent of clinical trials, which are critically important, we want to be able to give patients effective treatments in
exactly.
sequence.
Yeah. And just the last point on this slide was the data that was also shared about this new relacorilant with nab-paclitaxel regimen, that they also found consistent data and in the group of patients that were older than 65, and that the regimen was also safe in this population. So this is also a good piece of information to have. Okay, now we turn to antibody-drug conjugates. This is kind of the Wild West, you know. This, like, we could make lists, very long lists. Here is a list of some of the data that has been presented. This was all at ESMO, and this really like highlights some of the results that came out with, and it shows how we have a growing number of antibody drug conjugate drugs to choose between. So much is going on. We are, investigating known targets such as folate receptor alpha and HER2, but also many new and exciting targets. CD86, NaPi2b is coming back, and then even B7H4 and a new target, TA-MUC1. So we can't go into detail about all of this, unfortunately. So I've highlighted a couple of results that I hope we can discuss in a little more detail.
Perfect. I
One,
call it managing the mayhem of antibody drug conjugates
I
because it
know,
is incredible the development that's happening in this space.
yeah,
And every meeting that we go to, there is data emerging about either existing antibody drug conjugates or new drugs
I
that are
know,
in development also.
very much so. So this study is the so-called Fontana study, where we heard results now are presented at ESMO. This is presented at ACD 5335, but I guess this drug also now have gotten another name, Torvustam. It's being called also, and this is one of the many results that were shared, but it's a really exciting result. The patients that were enrolled in this Fontana study were recurrent platinum-resistant ovarian cancer patients. This was a combination of a phase 1 and phase 2 portion of the trial that they shared the results from. And to enroll, at least in the phase 2 those portion of the trial, people did have to have at least 25% of cancer cells with any level of folate receptor alpha. In general, for many of these trials we're talking about, that enrolling platinum-resistant ovarian cancer patients, typically people have a lot of prior treatment, which is also shown here. Lots of patients had prior bevacizumab and prior PARP inhibitor treatment. But what was really exciting here was a very encouraging overall response rate. We saw 53.6% of patients in this study actually saw tumor shrinkage, at least 30% of tumor shrinkage, in this study. I don't know if you have anything to add.
No, that's exactly what I would share. And one thing I want to just level set as we talk about all of these antibody drug conjugates, as Mette alluded to, overall response rate is a term that we use to make sure that we're all speaking the same language as we interpret results from clinical trials all across the globe when these trials are conducted. And for someone to have a confirmed ORR or response rate, they have to have at least a 30% reduction in the aggregate of their lesions on imaging. The term
Mm-hmm.
that we use as providers is called RECIST criteria, RECIST,
Yeah,
if anyone wanted to look it up. But that's not disease control or any reduction. So you may have a much larger population of patients that
exactly.
see some benefit and some reduction of the size of the tumor. And that's why, as you're trying to make sense of this data and understanding, well, what does this mean? This is exciting data, and we're going to go over many different drugs, and you'll see similar numbers. But this now has to be examined in a confirmatory study. And in those studies, we're not looking at objective response rate anymore. We're looking at the progression-free survival because
Hmm.
that allows us to capture all of those patients who have a benefit, meaning their cancer may be shrinking a little bit, but they're deriving a benefit for a long time, and that's important for us to see. So this is exciting data. It's provocative to see these efficacy signals. We're now also trying to expand. You'll notice that many of these, whether they're a lower threshold of expression of a target, here 25%, some don't select for a target. We're trying to see, can we
Exactly.
expand the opportunity? And
Yeah.
I'll pause there as we go along and review more data.
Exactly. We have a lot to talk about, but also, and this is of course also early for this trial, so they mentioned that they have a follow-up, and so it seems like the responses, they stay, they yeah, they continue for a reasonable amount of time. There was another very similar drug, LY4170156, which is another antibody-drug conjugate also targeting folate receptor alpha with a topo 1 inhibitor. This was actually result from a phase 1 trial with this drug, where they did not select for folate receptor alpha, and people were heavily pretreated. Again, people had lots of different treatment, both with prior bevacizumab, PARP inhibitor, and also a proportion of patients who had actually had prior mirvetuximab. And as you mentioned, again, using the criteria of overall response rate, we again saw at 50% of these patients actually saw, as we talked about, at least a 30% reduction in the aggregate tumor. We did also, in this case, have a report on what we call the disease control rate, which is what you alluded to, where some people also benefited by getting stabilization of disease. So a large proportion of people who enrolled in this trial really benefited from the treatment.
Yeah,
So another exciting drug.
I couldn't agree more. And again, you highlight an important point, which is we're also starting to look at patients who receive one ADC,
Yeah,
progress, and then receive another. It's very early on, and there are only a handful of patients enrolled in some of these trials that looked at that.
yeah,
But we're also seeing efficacy. And that's very important because I don't imagine a world where it's just going to be one antibody drug conjugate. I see a world where we're going to see many options for our patients. And as these drugs go through the larger studies and ultimately, hopefully, gain FDA approval, we're going to start to use these kinds of medication in sequence, and it's going to obligate us to use that kind of real world data to understand what the benefit might be. They've done that in breast cancer, but we also know not all diseases are the same,
yeah,
meaning the
exactly.
data from breast may not be what we see in ovarian cancer or endometrial cancer. It may be different. So I'm excited to start to see this data come up about using antibody drug conjugates after
Yeah.
antibody drug conjugates and what it might mean.
And in this case, it was, two antibody drug conjugates that both recognize the folate receptor alpha molecule, but between mirvetuximab and this drug, they had different what we call payloads, so different types of chemotherapy that was brought to the cancer cell.
Yeah.
Um, Another very exciting result that also was presented was the phase 2 portion of the REJOICE study, which studies the RDXD ADC, which is an antibody drug conjugate that recognizes a marker called cadherin 6 or CD8-6. Again, in this phase 2 dose optimization study, they actually did not select for the CD8-6 expression. We do believe that, like the vast majority of ovarian cancer, has CD8-6 expression. And again, we kind of seem to be hitting that 50% mark more or less all the time when we talk about ovarian oral response rates. Again, in people that have received prior bevacizumab, prior PARP inhibitor treatment, we saw really encouraging activity of this new antibody drug conjugate. And the phase 2 portion here did finish now, and they found the best dose that they now will move into the phase 3 portion of this trial that, as I understand, will start soon. I don't
That's
know if that's
exactly
in,
right.
yeah,
No,
yeah,
that's exactly right. And I think here, something that may be a new term for
yeah,
those of you listening is this idea of dose optimization. But this is actually something that's now become integrated in the development of cancer drugs. Whereas historically, we used to run studies and we used to say, this is the maximum tolerable dose. Well, that's not acceptable anymore. Now we have to design trials that randomize to different doses to look and see, are we choosing the right dose that's efficacious, that results in less treatment-related side effects for our patients to move forward? And that's exactly what this phase 2 trial was. It randomized patients to 3 different doses of the drug.
Yeah.
And then that's helping inform what Mette alluded to, which is the dose that we are going to now use in the phase 3 confirmatory trial, which is 5.6 milligram per kilogram. So hopefully that's a little pearl that you guys can take away from this and understanding how we're even doing these studies to inform dosing. Because I know many patients will commonly ask, why is that the dose of the drug, and how
Yeah.
did we decide on that?
Yeah. No, that's really integrated into many more trials now, and much more work on determining the optimal dose. Yeah. Finally, I just also wanted to kind of share this abstract. This is an abstract that describes phase 1 dose escalation results. So, early on, but still very exciting for a new drug that's called Top 40. And this is actually a drug that now is, of course, again, an antibody-drug conjugate, but we're back at actually targeting this marker called NaPi2b. I don't know if you want to kind of like discuss this a little bit. We did have a drug earlier that seemed very efficacious but had some side effects. But now we have a completely new drug called Top 40 to target NaPi2b.
That's exactly right. And I think that's important for us to recognize, which is if you had a prior development program, a drug that was developed to target this surface antigen or protein, and it wasn't successful, we have to remember these antibody drug conjugates are very complex. These are
Yeah.
composed of the antibody, which is the part that recognizes the cell surface protein, the linker, and then as Mette alluded to, what we call the payload or the drug that's attached to it. The chemistry of the linker, the stability, the payload, all of that matters. So because a prior NaPi2b program was actually ended because of treatment-related side effects, doesn't mean that we can't move forward with a different antibody drug conjugate with the same target and see success. So it's actually nice to see a resurrection of this target potentially with a different antibody drug conjugate. And again, this is not a typographical error to everyone who's on.
It's
The
50%.
ORR is again 50%. So you're seeing a very consistent signal across all these antibody drug conjugates with an overall response rate of about 50%. Here, a disease control rate of 96%. And so it's again giving us confidence to say, well, can we also move this drug forward to develop in the ovarian cancer space?
Yeah. And I think this just goes to show that we have so many exciting options. And I just put together this outline of the phase 3 clinical trials with antibody drug conjugates that are currently ongoing, and some trials, the ones that are start on the right-hand side, are trials that are not yet recruiting, but are planning and upcoming. And I'm sure many more will follow in the future based on all the results we've seen. But it's very exciting to see that, we have historically had the results with antibody drug conjugates in the platinum-resistant patient population, and we do have, you can see, have many different trials right now that still are on investigating this different new antibody drug conjugate also in the platinum-resistant population. But what we are also seeing is that these antibody drug conjugates are moving into the platinum-sensitive clinical situation, both as treatments and also as maintenance treatments in combination with bevacizumab or alone, and actually also have moved into the maintenance treatment for people that have finished first-line treatment with carboplatin and paclitaxel. So I don't know if there's anything you want to kind of highlight. This I know is a very busy slide, but I just really hope it conveys that so many options. And this is just the phase 3 trials. If we added phase 2 trials and phase 1 trials, we have probably hundreds of trials.
Dynamic time. If there's one take-home message for me from this slide, it's for all of our patients who are looking for treatment options. We have so many clinical trials that are either open and enrolling or will be open and enrolling in the future, near future. So please be proactive, have the dialogue with your treating physicians, ask if these are available, if not at the institution, regionally, whatever it may be, because as you saw, the preliminary efficacy data from these antibody drug conjugates is exciting. And if there's an opportunity to be exposed to these drugs or have them as a treatment before they're approved by the FDA, I think we'd want to capitalize on that opportunity to try to improve outcomes. So, it is a wonderful time because there are so many clinical trials available. We just have to make sure every one of our patients is aware that these options are out there and can advocate to try to get access.
Exactly. Yeah. Unfortunately, this is not only in ovarian cancer. endometrial cancer, we also have some very exciting developments in ADC therapies. These are some of the results that were presented at ESMO and IGCS. Rina-S is an antibody-drug conjugate, again, that recognizes folate receptor alpha. It has been developed, it's being developed both in ovarian cancer, but now we have also seen that this drug actually has encouraging activity in endometrial cancer patients. This was a study that was presented at ESMO, where we really investigated the activity of this drug in patients who had already received prior platinum-based treatment and also prior immunotherapy, with a large proportion of the patients also being like kind of with a more difficult histology. And we did see again, I don't know, I'm really not just like pushing copy paste, but again, in this 100 milligram per meter squared group of patients, we did also see 50% response rates and really, really high disease control rates, so really high benefit for patients. Basically, everyone benefited in that group. I don't know if you have anything you would like to add about this.
Exactly right. And this shows us that we're also seeing an evolution of the different targets and the different disease settings, meaning now folate receptor alpha in the endometrial cancer space when it wasn't previously. And also the data provocative enough to inform a phase 3 trial in the patients with recurrent endometrial cancer comparing Rina-S, rinatabart, sesotecan to a physician's choice chemotherapy option. So so exciting again. And the same comment I made a moment ago about our ovarian cancer patients and an abundance of trials, I will say the same thing for endometrial cancer patients who are dealing with recurrent disease. A lot of clinical trials either active and enrolling or will be active and enrolling soon. So please, please make sure that you are advocating to learn more about what might be available.
Exactly. And just to briefly touch on some of the other results, this is a result studying another antibody-drug conjugate, sacituzumab govitecan, that is already in a phase 3 clinical trial for endometrial cancer patients. I don't know if you just want to touch on the results that were shared at IGCS.
Yeah, this was actually what we call an investigator-initiated trial that was led by Dr. Centine at their institution. And what you can see, interestingly, the vast majority of patients that were enrolled had very aggressive kinds of uterine cancer, serous uterine cancer, or what we call uterine carcinosarcomas. And despite having these aggressive cancers and previous lines of therapy, we did see a response greater than what you would see with physician's choice chemotherapy from other phase 3 studies. So, and this is irrespective of expression of the surface marker, which here is an antibody or a protein called TROP2. So its preliminary efficacy is good. This is what actually helped give confidence to the phase 3 clinical trial, as Mette already alluded to. And that study is active, ongoing, and has done tremendous with accrual nationally and internationally. So we're eager to see whether sacituzumab govitecan will be an option for patients with recurrent endometrial cancer who received previous chemotherapy and immunotherapy.
And another drug that also where we saw results again at IGCS was then also another TROP2 ADC, sacituzumab tirumotecan or sac-TMT. I'll let you also just briefly talk about those results.
Yeah, exactly the same. So this is a TROP2 directed antibody-drug conjugate. Once again, both of these drugs have a similar payload, which is the chemo drug is a similar class of drug, but they're still different and distinct. Here again, 65% of patients with 2 or more prior therapies. You could see the distribution of the kinds of endometrial cancer. We call that the histology is a bit different in this study, but yet the overall response rate is about 31.5%. And this informed the confirmatory phase 3. So as was already alluded to, we have 2 phase 3 trials. We have the ASCENT GYN01 or GOG 3104 study. We have the TroFuse trial in endometrial GOG 3095. Those are looking at sacituzumab govitecan and sacituzumab tirumotecan in recurrent endometrial cancer, and we're eager to see what those studies show us.
And I just actually have listed that some of these. I actually believe that when I made this slide that the tirumotecan trial for recurrent actually I already have finished accruing patients.
Yes.
Yeah, exactly. But the same drug is now also being investigated as a maintenance treatment in first line. So again, the picture is lots of different options, many different trials that are being planned or already ongoing. I don't know if you want to talk more to that.
But as you can see here again, we have various clinical trials, different disease settings, different targets, different antibody drug conjugates. So it just again emphasizes this opportunity. And I just want to hammer that home because I really view it that way.
Great. Finally, I'll just briefly talk about cervical cancer because, to no surprise, these types of drugs are also used in cervical cancer. I'll let you take the word about
Of
TIVDAC
course.
and the trials that we
So
heard results from.
yeah, tisotumab vedotin, as many may be aware, is an FDA-approved option for the treatment of patients with recurrent pretreated cervical cancer. We have the opportunity to use tisotumab vedotin, and that was based on a phase 3 trial that was completed that showed an improvement in progression-free survival and overall survival for cervical cancer patients. But we also see an opportunity for new treatment strategies. Why? Because TROP2 is a protein that's very highly expressed in cervical cancer. So naturally, it was looked at, these same antibody drug conjugates that we just talked about in endometrial cancer, sacituzumab govitecan and sacituzumab tirumatican, are being examined in cervical cancer because of earlier line data, phase 1 data that showed promising efficacy. So this is an
EMO.
example of a study that was shared at ESMO in 2025 looking at sacituzumab tirumatican in patients with advanced stage or metastatic cervical cancer. And you could see they've had prior chemotherapy, they've progressed, median of 2 prior lines, but the objective or overall response rate is 24%, which is much better than what we see with just regular chemo drugs. So although it's not the 50% you saw previously in some of the other studies, it's still substantially higher than what we see when we give some of the chemotherapy drugs, which we know from prior studies have a response rate of about 5 to 6%. So
Okay.
again, here is a great opportunity. And again, the disease control rate is 72%. So
Yeah.
even though you may not reduce the volume by 30% of the tumor, you can help patients benefit by some reduction or control for a period of time.
Yeah. And similarly, we also saw results from this drug here. Yeah.
Correct. The sacituzumab govitecan. Again, this was a study. This was presented at a meeting called ESMO TAT, and this was looking at sacituzumab govitecan in patients with recurrent metastatic cervical cancer. Importantly, a large proportion had 2 prior lines of therapy. Nearly 70% had immunotherapy. That's very important because many of our cervical cancer patients now are receiving immunotherapy very early on in their treatment. So we want to understand the efficacy of this drug after immunotherapy. And what you can see here is an overall response rate of 43%.
Mhm.
Super exciting data. And again, this is informing the design of a confirmatory trial as well. And just so everyone's aware, the sacituzumab tirumatican, there is an active phase 3 trial. It's an international study looking at that drug versus a physician's choice chemotherapy to see if it is going to be available for our patients with recurrent pretreated cervical cancer. So yet again, dynamic a dynamic time, many therapeutic opportunities, and really we're eager to see what this may show.
Yeah, that was listed on the prior slide where we had both the results and also the ongoing phase trials. Lots and lots of data. And I just want to say thank you. Thank you again, Ramez, for joining me. This was really a pleasure. And thank you for everyone who decided to listen to this webinar. I hope it was helpful. If you're interested in more science, information, education, OCR has educational workshops and what we call staying current sessions. So we discuss treatment options and clinical trials. And here's a link if you're interested in that. And I also wanted to encourage you to sign up to receive updates about OCIA's Living Lab and the Discovery Lab. So with that, sorry.
No problem. Thank you,
What
Anameta,
happened?
for giving me an opportunity to join. It was wonderful, and thank you all who are attending. We are eager to continue to educate and to help people understand what their options are.
Yeah. Thank you again, and bye.